to talk about all things autopsies, but before we dive into that, I was wondering if you could just explain what it is that you do.
So formally, so for the past 3 years or so, I've been serving as a forensic pathologist and medical examiner. I perform autopsies. The difference is, formerly, those were community-based autopsies. So people that either die at home and don't have a physician, young people that die without a significant medical record. So again, they don't have a physician that's comfortable signing their death certificate if they're rather healthy. And then your unnatural deaths, so your homicides, your suicides, your accidents.
As a field of science, what was it that first drew you to pathology?
So I'm a little bit different. I actually started in general surgery. So I went to med school, dead set on becoming a surgeon. I started my training in general surgery. I loved the human body, anatomy, working with my hands. I just didn't fit the stereotypical mold of what a surgeon is. And I found myself not enjoying life. And so I did some reflection and decided to switch into pathology and specifically forensics for a multitude of reasons. One, still working with the human body, my hands, and anatomy. Two, tons of teaching involved in pathology. Pathologists love to teach everything we're seeing under the microscope, things we see with our eyes. On a more personal note, I lost my father at a fairly young age as a result of an accident, and some other people in my family and life. And so I know what it's like to be on the other end of the care we provide as forensic pathologists. And that never gets old, talking to the families. We don't talk to every family, but we talk to a lot. We talk to a lot of, unfortunately, grieving mothers who lost their child. And no matter how tragic the death, they're always so appreciative at the end of the day.
Is there a typical day in pathology?
Mainly, you go in, you read your list of cases you've been assigned, and then you go perform the autopsy. And so that means you gown up, you put on your PPE. So cover your hair, cover your eyes, cover your hands, your whole body. We don't work in isolation. So the office is usually 24/7. So we have a whole team of investigators. And so they're the ones when a death is reported, they go to the scene and they talk to the family, friend, roommate, people on the street, wherever the death occurred, and they get our story. So they get the facts. What do we know happened? When was this person last seen alive? Um, were they seen in person? Was it via text, a phone call, or have they not been seen in months? Were they complaining of anything? Did they have belly pain? Did they have a headache? In addition to them, we work with a whole team of autopsy techs. So our technicians, they help undress the person. So everyone that comes in, we do an external exam. And so we look, we see signs of trauma. We always want to make sure, did someone get clipped by a car? Did they fall? Did they get shot? Did they get stabbed? And so we'll take pictures, we'll collect any evidence. So evidence is really big for anything that's potentially being prosecuted and going to trial. Say a hit and run. Do we see paint chips? Do we see impressions of a car bumper? Do we see glass? Gunshot wounds? Are we seeing soot that helps us determine how far away that gun was from the individual? Do we see bloody footprints on them? Were they stomped? Things like that. But then we undress them and we look at the entire body from head to toe, clean. So we'll clean the body up, and our techs usually do this. We help. And then we direct photography, always noting any major injuries that are significant that might have caused or contributed to death. We also just document, what color are your eyes, your hair, especially some of these deaths will have, say, in a nursing home or somebody elderly or vulnerable or compromised, so disabled kids in the care of someone else that needed that care to survive. But we'll look just overall cleanliness, are the hands hold a lot of evidence. So are your hands clean or dirty? Does it look like no one's bathed this individual and given them attention for a while? Or does it look like somebody was trying to do a good job? That all plays into the story. And then the actual autopsy happens. And so we do the standard Y incision, reflect, take off the chest plate, and then we look at the organs. Does everything look, even without taking them out, does it look healthy? Do we see a surprise cancer in somebody who is having difficult breathing or digesting their food? And then for trauma, what organs are injured? What blood vessels are injured? Did the gunshot wound go through the spine and cause paralysis? Especially if it's high up, well, then you stop breathing and that could have killed you. And then from there, the techs take out the organs, they hand them to us, and we go organ by organ, we weigh them. There are expected ranges of weights for every single organ in your body, based on your sex, based on your age, height, weight. So we have a range. If there's disease, sometimes we can see it with the eyes, but sometimes we can only see it under the microscope. But we can tell if an organ's way too big, way too small. Has it been infiltrated with an infection, cancer, scarring? And then so we take notes of the weight. We make teeny, teeny sections the size of about a postage stamp, maybe thicker, and we put them into cassettes that get translated into slides that we look at it about a week or so later under the microscope. And so we do the whole body, usually your major organs, your brain, heart, lungs, liver, kidneys, and then anything else that pops out as potentially abnormal. So that's a typical day if you're in the post room or the autopsy suite. If you're not, you might be on the phone with law enforcement following up on information you need. Maybe the fire department, if it's a fire involved death, we always want to rule out arson or foul play. You might be following up on medical records. Some people come in with a lengthy history, medical history. You have to figure out what is going on, especially in those care settings. So basically, you're juggling a lot of different bits of information from different cases. Sometimes you're teaching, sometimes you're testifying, sometimes you're doing research, sometimes, depending on the office you work in, you actually go to scene sometimes, especially the in custody deaths. So people dying in prisons or jails, you might be called to go evaluate the scene to see if the story you're getting told lines up with what you're seeing with your eyes and that knowledge you have coming in as a physician. So that's a typical day.
It sounds amazing. It must feel like spinning an awful lot of plates at some points, trying to focus on all that stuff at once.
Some of them are emotionally draining. I don't think we talk about it a lot, but if you imagine, we see the whole spectrum, and they're all, people dying before they should. So one thing, if you see someone that lives to be 100 and you're doing their autopsy, they come, that's a full life. But some of these, you're seeing babies, infants, kids, and so much potential in life that has been cut short. And so sometimes, we'll save that for a day to itself, and do. But you find your rhythm. But it's definitely juggling, spinning a lot of plates. The pandemic, just like everything else, has made everything worse. So a lot of offices have been struggling to keep up, and in doing so, have adjusted some of their protocols. So not everyone that comes to our office gets a full autopsy. So people might not know that. And so every office has standard operating procedures or guidelines. National Association of Medical Examiners name. They're a big organization, so they maintain accreditation, making sure we deliver consistent quality of care. Not everyone needs an autopsy, so take that 100-year-old. 100-year-old, and we get this, especially where I am now in Seattle. There are a lot of very healthy people. They walk all the time, they eat well, they go hiking, but they don't have a doctor. And you know what? They made it till 100, so you could argue maybe they didn't need a doctor. Well, we don't really need to autopsy 100-year-olds. So sometimes your exam is your medical record review by us, the doctor, and then a physical exam just on the outside, just making sure there's no evidence of injury. I think I forgot to add, we have postmortem imaging, excuse me. So that could be X-ray, CT, MRI scan. So we use that in conjunction with our exams. Especially the CT is gaining popularity. You can see so much detail that we don't even necessarily see at autopsy because we're only doing the thoracic cavity in your head. Well, what about extremities? Sometimes you have teeny, teeny fractures or injuries or different things. So a lot of times, if we don't do a full exam, we'll do the external and some type of imaging to make sure we're peeping inside, if you will.
And you mentioned earlier that when you begin an autopsy and so you're doing the incisions to look inside, that you can spot when things aren't quite right. Did you find when you started that it took you a long time to kind of get your eye in and be able to see that stuff?
Every country is a little different in your qualifications. But the general thing is you do your residency training first. So you do high school or grade school, undergrad. In America, you do undergrad separately. Then you do medical school. And then here you have to be an anatomic pathologist first, which means at least 3 years of learning every way disease presents in the human body, what that looks like grossly with your eyes, what that looks like under the microscope, what happens when that disease is treated, how it changes. So you have 3 years of very intense training on seeing the whole range from normal to cancer. You have to have some experience in forensics. Everyone has to do hospital autopsies. So you're coming in with about 3 years of doing nothing but looking at disease. So you come in learning what normal is or anticipated or expected, and then what that whole range of disease looks like. So you come in with your eye already trained, and then you get more finely trained to also start including trauma and different things like that. So that helps a lot.
Great. And I guess when you look at something and it's not quite clear, you mentioned that you have these tests you can use. Are there any that you kind of regularly use, or does it entirely depend case to case?
So that it depends not only case to case, but office to office. So my last job, we put histology in on every single case. And histology is what things look like under the microscope. So we would always sample the brain, heart, lungs, liver, kidneys. Those are the major organs that if something goes wrong, your chances of dying or being really sick are increased. Um, and so we do that. And also, we don't work in isolation. So there are going to be hard cases unless you're in an office of one. And I think those are difficult cases, office to work in because you don't have colleagues to bounce ideas around, right? In Chicago, I was in the office of about 20 people. In Seattle, it was about 6 of us. So you always have people to, hey, can I get you to look at this? Hey, this is the case. Does this add up? It's not really adding up to me. Am I missing something? And we do that every single day. There's a morning conference that starts your day where the whole office, everyone that's in, they review every single case that's coming in. Every now and then you get a case where it stumps everyone. And that's when you just exhaust all your testing. So that means you submit more histology and maybe from other organs. We always put in additional heart sections because sometimes these natural deaths, they're actually a very, very subtle myocarditis, which is an inflammation of the heart. And it's patchy, which means it's not everywhere. So you could have missed it on that little postage stamp. So we'll throw in more sections, or we'll start looking at the actual conduction system of the heart. So what makes the electrical impulses go through that makes your heart beat? We'll actually section that. Sometimes we'll call in specialists. Again, we don't work in isolation. So there's neuropathologists that are specialists in the brain, cardiac pathologists, your heart, pulmonary pathologists, and pediatric pathologists for your more complex. So we'll actually send either the slides to these specialists for their review, since that's what they see all day, every day. Depending on the case, if we have knowledge before, we'll call them into the office and they'll be there for that step of the autopsy. We have forensic anthropologists and odontologists. So anthropologists, that's your skeletal system, your bones. And so sometimes, if you can imagine, not everybody that comes in, they die and they're immediately found. Some people are found months later, years later, and all that's left is what? Your teeth and your bones. So how do we know who you are or what happens? And so we'll consult them, and they do extensive surveys and review and analysis, and they can evaluate more likely were you male or female, give you an age range, and they can also assess for trauma.
You mentioned earlier about how you like to take blood or cerebral spinal fluid. Is there a kind of time cap where beyond a certain point it's no longer possible to extract those things?
It all depends on how quickly the body decomposes. So if you imagine normal body, normal circumstances, you died, say I died in this hotel room. Within a certain number of hours, and there's a mathematical formula, my body temperature would be that of whatever environment I'm in. So I'm in an air-conditioned hotel room, not bad. Say I was out in the desert, pretty bad, right? It's going to rise. And the hotter you get, your tissues start breaking down quicker. And that includes your blood vessels. And so blood is our preferred specimen. Once that goes, sometimes you still have fluid in different places, or even your body's decomposition fluid. So the fluid that, as your fat, as your cells decompose, you can actually test that. The trade-off is With blood, we like it because it says what was circulating in that person's body right at the time of death. So it gives you an active level. When people decompose, it more turns into a yes or no. We can't give accurate levels usually, but we can say this substance was in the body.
Are there like key reportings that you give each time, and who do you give the report to?
We're very standardized. So we have standard templates for the actual autopsy report. And so the actual printout, whether that's electronic or paper, you'll do everything from the date and time you did your examination as a forensic pathologist to, again, the external exam. So everything I document from your hair color to your nail length to any scars you have, tattoos to help identify you if we don't know who you are. And then usually there's a trauma component. And so if there's any trauma, we'll document that in a section. And then there's the internal exam where we give organ by organ system. How big was the brain? How much did it weigh? Were the blood vessels congested? Was it swollen? Same thing to the heart. Did the heart look as you would anticipate? Were the coronary arteries, did they course appropriately? Were they stenosed or narrowed at all? Was the wall of the heart thickened? And so we do that organ by organ, and then we do our summary and opinion. And so usually you start with, this was a, I don't know, 25-year-old man who was found dead on the street, no known medical history, autopsy revealed, yada, yada, yada. Toxicology was or was not contributory to death. And then you do your cause of death is blank, manner of death is blank, and your manner being, was it a natural death, which is caused by disease or aging alone? Homicide, death at the hands of another, suicide, death by your own hands, and then accident. There's no intent component to cause death. So if you're in the community, so in a medical examiner's coroner system, usually the next of kin, so family most likely, will get a copy at their request, and usually that's communicated through the funeral home.
Why is it so important that we establish a cause of death in cases where foul play isn't expected?
Usually, so aside from the medical legal implications, public health statistics, right? So our lifespans are framed by a birth certificate and a death certificate, and those are the bookends of your life. So we want to know on a community level how people are dying, whether that's just in your town, township, city, and then also your country, right? Take the hot topic of maternal mortality, or people who are pregnant dying, whether that's during labor or after death. At least in the US, it's been a big topic because now that we're actually tracking it through the death certificates, we're finding out we're not doing well as a nation, and we're not doing well compared to other nations, kind of on equal development and economic standing, if you want to classify countries as such. And so we want to know how we're doing. And then the follow-up is, how can we do better so that more people can live fuller lives, right? And longer lives. And we want to make sure that if people are dying before they're expected, and there's an average life expectancy, and we know there's a lot of disparity between that, with different races having different life expectancy outcomes within a certain geographic area, we want to know what those are. So then again, public health interventions, whether that means, hey, we're noticing this whole community is dying at a higher rate of, say, heart disease. Well, a lot of that is going to come if they have a doctor, from a doctor, but also us. So are we finding that people that tend to die at home of heart disease are, I don't know, Black men in America? Maybe. And so that's opportunity to try to connect people to different public health programs, primary care physicians. One population I'm interested in is those who have been incarcerated, and then they're released. There's a huge gap reconnecting them. They have to get employment. There are no follow-up appointments generally made for people. And so not uncommonly do we see so-and-so found dead, was recently, released from jail or prison within a few weeks. And so the idea is, if we start tracking these deaths and seeing how these people die, well, maybe there's something we can do while they're incarcerated, they being the US government or your state government, that can connect these people to these services, so they're not just, wandering the streets because they can't get housing. If you can't get housing, it's really hard to get healthcare, to get to appointments, those transportation issues. So in short, those non-legal type cases, we do it just to get a pulse on what is killing us as people.
Yeah, I think that's a really interesting point, and why I feel like it's quite important that these kind of discussions happen where everyone can learn more about pathology, because I think often you think it's really just about complex, murder cases, but actually it's a field of science that reaches all of us.
Mhm. Absolutely. And I think, people have that misconception about what we do because of all these shows, right? And that's all you see on the shows are the murder cases. You look at every year, each office will put out what's called an annual report. And so it'll break down all the cases they saw in the year, how many, and then manner of death, so how many homicides, suicides, natural. Almost across the nation, your most common manner of death is natural.
And in the cases when you are working with homicide, I guess you don't know at the start. That's the part of the purpose of the autopsy. Does the process change significantly when you're dealing with suspected foul play, or are the procedures still largely the same?
Anytime suspected play is potentially on your radar. A lot of times, though, you have your obvious ones where someone's found dead in the alley with 10 gunshot wounds. Well, that's a homicide. But in cases, not infrequently, we'll get a case in a hotel or motel room, where it's usually like a young woman was seen entering with a man, and then suddenly she's dead. And so some of those will just be drug overdoses, but some of those will be fatal domestic violence or intimate partner violence. And so from when you're triaging the case, you tell your technicians this will be per our homicide protocol. Now, that doesn't mean it's a homicide, but that means we're going to collect the evidence we would if it was a homicide. So swabbing the fingernails for DNA, right? Because if somebody's clawing at someone, there's going to be little traces of it here. Sometimes you do neck swabs, different photography. We'll examine the neck slightly different. And we'll do a very slow layered approach where we look at every single layer of muscle in the neck for hemorrhages, for trauma. Most in custody deaths are not homicides. However, you would be foolish to not go into every in custody death and treat it like a homicide.
And in those cases, the autopsy can be pivotal in a case. Does that feel like a lot of pressure for you?
So far, I really like testifying, but I also like teaching. And so a lot of testifying is one, making sure you're not being tricked into saying something, so talking slower. But two, we're taught you don't speak to whoever's asking you the questions, you direct your attention at the jury. And so all you're doing on that stand, and I think this helps decrease pressure, at least for me. I'm not making or breaking the case. The lawyers make or break the case, right? Because my testimony is only one of several testimonies. And if they're doing a good job, but as long as I just don't say something heinous, um, the hopefully the truth prevails, whatever side that is, right?
That's one of the things that you often find in TV. The stereotype there is that you've got this one pathologist and they deliver a soliloquy that lands all of the key facts of the case and swings the whole thing. Do you find when you see these things on TV, are there a lot of common misconceptions and misrepresentations like that?
Oh, I'm sure. I will also say I'm the person that barely watches TV, let alone crime related things. The few I've seen, though, I think the biggest parts to me are like what happens in the autopsy room. It's usually dark, poorly lit. It's the opposite. We have a lot of lights. We have to take excellent photography. And then people sometimes, are eating in there. They're not wearing, PPE. They're breathing in this air that could and the reason we have PPE, the reason people are wearing, masks during the pandemic, we have no idea what's going on inside of people. So there's still TB, tuberculosis. People still have tuberculosis. If we're using a saw to take off the breastplate, you can aerosolize the lungs. And if somebody has TB, well, you could get TB. You're exposed to TB. Same thing. We treat everybody like they're potentially infected with who knows what. And so that's why we wear gloves. So a lot of times you see the eating in the autopsy suite will never happen. Inappropriately protecting themselves will never happen. I think one of the big things that annoys most of us is the turnaround time. So finish every case and they can give you an answer that day. Most cases, unless they're, gunshot wounds, stab wounds, things like that, well, there all those studies I told you, toxicology, histology, you're talking weeks to months. And so I think that creates this false expectation for a lot of families, that they're going to get an answer that day or the next day.
And so to give people a more kind of accurate view of what it's really like what would you like to say to someone who's considering a career in pathology?
We love people who want to be forensic pathologists. So, say you're in medical school, say you're in high school, and you're seriously interested in being a forensic pathologist, I would reach out to the office and say, hey, I'm in this stage of my career. I'm looking to become one. Most offices would love to have someone come in shadowing that has any interest in forensics, because we know the best way to figure out if that's for you or not is to come in and see yourself. We're the heart of the hospital. We're the lab. People tend to not see us. We see everybody. We see your biopsy, we see your cancer, we see whatever, but you don't necessarily see us. And so there's a movement now, to show our faces, to say, hey, these are the people behind your diagnoses, and we're great, and we'd love to have you, and we're pretty fun to work with.
And I noticed on your website that it mentions that you do work about abortion rights and then also the hiring and retention of Black pathologists. So I was wondering if you could just talk about a bit of the other stuff that you do on top of your autopsy work.
As we all know, Roe versus Wade was recently overturned in America. And without getting too political, or political and all, we know that's going to have negative consequences, right? We just know it. I'll just say this, the US at baseline does not do a good job keeping pregnant people alive and well throughout their pregnancy or in the first year after being pregnant. We already have extremely high maternal death rate. We know there's disparities within that community, specifically with Black and Indigenous populations faring the worst. And so, regardless of your political affiliations, the truth is, if we're going to force more people to carry pregnancies and deliver them, more people are going to die, just statistically, because we don't do well. And so that's an issue. And I was actually brought into that project by some other pathologists I know that I'd either worked with or done podcasts with, or given lectures with. And we were all like, hey, how do we approach this? Non-politically, but from a public health perspective, from a pathologist perspective, because if you imagine, the pathologists, especially in the hospital, some of them are dealing with what we call products of conception. And so, can I even use that terminology now? If it's conception, is that going to now implicate or indicate an abortion? And then is that going to have some negative consequence? So we just came together to do a brief editorial, highlighting again, and I think this is a consistent thing in some other things I will mention. A lot of times you'll have primary care physicians speak out. We've kind of sat in the back historically. Pathology really hasn't spoken up. And so we want to say, hey, this is important to us as pathologists, that we need to recognize there are going to be more death in the community. Forensic pathologists need to be given a platform to speak. And so, yes, if you look again at the physician workforce specific to forensic pathology, of those 400 or 500, maybe 600, maybe there are 40 Black forensic pathologists in the nation. Maybe. I don't even know if they're all in practice. And so how do we do better? And why does it matter that we do better? Well, it matters because multiple things. I can tell you on the phone, there will be a lot of times, though, there's an overrepresentation, if you will, of underrepresented communities in the practices we see. So we see more Black, Latino, Indigenous, LGBTQIA, disabled, all overrepresented in different types of deaths we see. I can tell you there's some conversations I've had where you could hear on the other end of the phone, as soon as that mom realized, that Black mother realized she was talking to a Black woman, her whole tone changed and she relaxed. And I think that's important because when we rotate through medical school, I know a lot of people were trying to get me to do primary care, cardiology, OB-GYN, and they kept saying, this is a great way to give back to your community. Well, this is also a great way to give back to your community because historically the US, there's a reason so many communities have doubts in all our systems, whether that's the criminal justice system, our medical system, our educational system. And so having people that look like them, having people that understand their community helps bridge that gap. We're trying to put more faces forward that are not just the historic representation we've seen in America. So trying to put more LGBTQIA faces forward. Trying to put single mom forward and let you know, you can be a single mom and be fantastic in your career. Uh, just the whole gamut, I think, is so important. Aside from that, I do so many things. But I'm also on our Washington State Maternal Mortality Review panel. And so it's a 3-year term, and we review every single death occurring in the state for someone who was pregnant and either died while pregnant or within that first year. And again, we're trying to assess trends specific to our state. We work locally. We're trying to diversify our doulas and our whole birth workforce, if you will. We're also working on a policy arm and like speaking to policymakers who can change things on a larger structural level. And every now and then you'll get this case of someone between 1 year, usually like 16 years, I mean, relatively healthy child that just dies. And usually the autopsy is negative. And so we'll review all those cases and make recommendations. And usually they're in the form of genetic testing to see if they inherited some little gene that caused, unfortunately, that child's heart to stop beating. And what's great about that is if there's another sibling or if the parents want to have another child, well, now they know, well, maybe we need to have an ICD implanted into our remaining child. So if they do have an arrhythmia, it can shock them and they can keep living.
Just finally, if people want to hear more about what you're up to and what you're doing, where could they follow along?
For now, I am still on Twitter. That's pretty simple with a very easy handle. It's just my name, Nicole Jackson, MD for medical doctor. That's my Twitter handle. Similarly on Instagram, I am on Instagram as well. Nicole Oxen, MD. Someone took my name. And then I have a website with links to everything. It's just throughdeath.com, through THRU death.com. And I'm always here for mentoring.
Amazing. That's great to hear. Well, thank you so much for giving us that insight into what it is that happens during an autopsy. I really appreciate your time today, and it was great to chat to you.
Great. Thank you so much for having me. This was lovely.